Dr. Deodatta is a very senior and respected nephrologist. Nashik. He has held various positions, and his heart is in nephrology. That's all I can say. And he's going to talk about SGLT2 inhibitors and what are the contemporary things about heart and the kidneys. Before he goes on to his lecture, it is known that the two complications which mime type 2 diabetics are heart failure and kidney failure, and there has been nothing much till a couple of years ago for these. And as was highlighted in the previous seminar also, now we are getting excited about newer and newer things, and they're coming one after the others. It's like the buses that you are waiting for in your school days. One day the bus doesn't come, and the other day 3 buses come one after the other, and the driver says, no, you sit in the next bus. So now we have in nephrology and in cardiology, and thankfully diabetes, before we forget that these molecules also have anti-diabetic properties, one after the other, GLP-1 analogs, SGLT inhibitors of one or the other type, and now Findrenone. So we are now having a splurge of medications which are now showing what we initially thought, that once this develops, nothing can be done. We as endocrinologists and people who treat diabetes had been accused of searching solutions for macrovascular disease, like microvascular disease, in glycemic control. That was wrong. What we have found is that through anti-hyperglycemic molecules and mechanisms that address the end organs, like we address retinopathy, addressing kidney specific orientation or attributes of a drug, addressing heart specific orientation of a drug, is going to make the difference. And he is going to highlight about what is already known and what was added in the ADA. Over to you, Dr. Deodatta.
Sethi and Dr. Das, and I'm the third nephrologist in the series. 2 more nephrologists have already spoken before me. And at the ADA, all of us know that SGLT2 inhibitors have created a storm in nephrology, in cardiology, as well as in the field of diabetes. And at this ADA, a lot of information was given about the heart failure data, especially in patients with heart failure with reduced ejection fraction. And a lot of data was presented about DAPA-CKD and the inferences from the Credence trial also. And then there was a review of a meta-analysis as far as data regarding SGLT2 inhibitors and CKD is concerned. So all of us know that as far as SGLT2 inhibitors are concerned, though they came in as anti-diabetic drugs, now there were a lot of other applications, and new information which was mentioned was that SGLT2 inhibitors have some effect on sirtuin-1 and FGF21, and they increase the gluconeogenesis, also increase ketogenesis. This results in reduction of the oxidative stress, as well as suppression of pro-inflammatory pathways and activation of autophagy, resulting in cardioprotection as well as nephroprotection. Now, all of us know that the standard mechanisms as far as the SGLT2 inhibitors are concerned in the kidney are natriuresis, reduction in blood pressure, restoration of the tubuloglomerular feedback, and of course the primary effect was proximal reduction in the proximal tubular reabsorption of glucose. That is how these drugs came in for control of diabetes. So based on what we know, we would expect SGLT2 inhibitors to reduce heart failure, hospitalizations, as well as serious renal events in any disorder where the heart and the kidneys are under stress. And therefore, besides type 2 diabetes, they have been used in CKD, chronic heart failure, and other disorders that accelerate the progression of heart and kidney disease. Now, there have been some other mechanisms which have also been highlighted besides whatever I have already mentioned. So one is about reduction in inflammation because of reduction in the pro-inflammatory pathways. The second important mechanism which has been highlighted is reduction in the sympathetic overactivity, even the central sympathetic overactivity. And one of the newer mechanisms which is highlighted is that the sympathetic activity which is produced from the kidney and which gives the feedback to the brain, to the central sympathetic nervous system. That also is affected by the SGLT2 inhibitors. This results in the central sympathetic outflow being reduced, and there are some studies to show that the MSNA activity in the muscles is reduced after use of these drugs. Similarly, as far as the kidneys are concerned, previously it was thought that they are primarily diuretic drugs, but again, that is now off the table. And a lot of research now on erythropoietin and SGLT2 inhibitors. They, of course, they increase the hematocrit levels, and it is shown, especially in the EMPA study, that with the introduction of SGLT2 inhibitors at the end of 4 months, they showed that the hematocrit increased, the hemoglobin improved, anemia was corrected, and this was probably related to the rise in the erythropoietin levels. So therefore, a lot of new mechanisms are being deciphered in both the heart as well as the kidney as far as use of SGLT2 inhibitors is concerned. Now, a lot of trials, so probably it is now time to change our terminology. We should stop referring SGLT2 inhibitors as only anti-diabetic drugs, but they are also cardioprotective and nephroprotective too. And in this connection, there are a lot of studies have been published and they were reviewed at the ADA. So if you just want to enumerate the heart failure trials, you have the, I'm not going to discuss each trial in detail, of course, but I'll just enumerate them: EMPA-REG, Canvas, Declare TIMI, Vertis CV, Credence, DAPA-CKD, DAPA-HF, Emperor Reduce, and of course the Soloist trial with sotagliflozin. Now, if you put all these trials together, almost more than 20,000 patients have been analyzed. And as far as the heart failure trials are concerned, mainly they have been the EMPA-REG, Canvas, Declare TIMI, and Credence. And as far as the renal trials are concerned, we have the DAPA-CKD data, and we also have the inference from the Credence data. So first, if you just want to summarize what is the evidence in heart failure, we already know that the evidence is very clear as far as the heart failure data with reduced ejection fraction is concerned, and in those people with HFrEF and those who are ambulatory and not hospitalized. In that, it is now coming in as a guideline that all these people should be on SGLT2 inhibitors. Now, the conventional treatment for heart failure with reduced ejection fraction has been, of course, RAS blockers, diuretics, ARNI, the MRAs, and beta blockers. And of course, in some patients who want to reduce the rate with drugs like ivabradine. But the newer guidelines probably are going to mention about use of SGLT2 inhibitors because there is enough data to show that there is reduction in heart failure hospitalization and cardiovascular death, and it also prevents worsening of symptoms. And in addition, all these trials also showed that there is a slow deterioration of kidney function in patients with heart failure with reduced ejection fraction. So there's a lot of now data emerging in the cardiorenal spectrum where people with primary heart disease and then going on to have kidney ailments because of the secondary issues also have benefits as far as reduction in the morbidity and mortality related to the kidney, as also with the heart failure with, and reduced ejection fraction. Not much data with the mid-range ejection fraction, but there is a lot of anticipation as far as heart failure with preserved ejection fraction and in people who are hospitalized with acute decompensated heart failure. So in this connection, a few trials will be coming in at a later date. One is called as the Emperor Preserved, where heart failure with preserved ejection fraction patients have been given SGLT2 inhibitors, and the results would probably be encouraging. We know that patients with diastolic dysfunction and those who have a preserved ejection fraction, especially also in CKD, we see all this subgroup of patients where we need some drugs to control the heart failure. So the Deliver trial as well as the Emperor Preserve trial are going to tell us about the importance of SGLT2 inhibitors in this particular spectrum. And then there are some other trials like the Soloist trial with the mid-range ejection fraction, and there's a DAPA heart failure trial for hospitalized patients with acute decompensated heart failure. So all these trials, of course, the results are not out, but in this connection, we probably will have a lot of encouraging data for the use of SGLT2 inhibitors. So this is about the data in the heart failure with reduced ejection fraction, and the upcoming data for the preserved ejection fraction. What about CKD? Now we know that the CVD and CKD benefits are present in patients who have pre-existing CKD with SGLT2 inhibitors. And here, of course, we are looking at the 3-point MACE data for the cardiovascular events as well as the renal events. Now, specifically, as far as the renal events are concerned, we are looking at three parameters. One is reduction in proteinuria, second is the decline in the eGFR, and third is the decline in the rate of progression of kidney disease. So it is seen that this is a class effect as far as SGLT2 inhibitors are concerned, because we have seen this effect in the EMPA-REG, Credence, Declare, TIMI, as well as the Canvas data. And here, the important point which was highlighted is that this effect is present across the spectrum. That means at all stages of GFR, and we know that the minimum GFR at which you can go is 20 as far as data of DAPA-CKD is concerned, and at all levels of proteinuria. So even if you have minimal proteinuria, probably SGLT2 inhibitors would act by way of their hemodynamic effect, and you will see reduction in all-cause mortality as well as 3-point the MACE as well as the 3-point kidney events. And in the future, probably we are going to see combination of other drugs also, like SGLT2 inhibitors with endothelin receptor antagonists like atrasentan in combination as renoprotection strategy in patients with CKD. And one last point which was highlighted in the ADA was that in patients with non-diabetic CKD of any etiology, it was highlighted that you can use the SGLT2 inhibitors for protection in addition to angiotensin receptor blockers. We know that we have been using ARBs for reducing proteinuria and for preserving renal function. In addition, you will be using SGLT2 inhibitors, but we need to develop some guidelines as far as use of these drugs is concerned. So this is the summary of what was presented at the ADA. Thank you very much. Over to you, Dr. Sethi.